Hello, my name is Danielle S. I'm a fourth-year general surgery resident at Swedish Medical Center in Seattle, Washington. I have no conflicts of interest or financial ties to disclose. Appendicitis is a common problem that general surgeons encounter, with an annual incidence of 100 per 100,000 persons per year affected in North America. Approximately 20% of patients have complicated appendicitis at the time of presentation and are typically managed with antibiotics and image-guided drainage as indicated. Patients may then undergo interval appendectomy 6 to 8 weeks later, when the majority of acute inflammation has resolved. Arguments for interval appendectomy include the prevention of recurrence and the possibility of an occult appendiceal neoplasm. However, the necessity of interval appendectomy has been questioned, especially in light of the recent interest in non-operative management, with some advocating to abandon routine interval appendectomy altogether. Arguments against routine interval appendectomy include the cost and the potential morbidity and complications associated with the procedure. The fairly low incidence of recurrence after treatment with antibiotics, and the relatively low incidence of appendiceal neoplasms in patients with acute appendicitis. As non-operative management of appendicitis gains popularity, it's important to know the incidence of occult neoplasms in patients with complicated appendicitis. Numerous studies have demonstrated a low neoplasm incidence in all comers with acute appendicitis, with the neoplasm incidence commonly being quoted as less than 1.5%. However, recent studies have shown that patients with complicated appendicitis may have a significantly higher risk of underlying neoplasm, as high as 29%. However, these studies have been small. Our study aimed to determine the incidence of neoplasms discovered during interval appendectomy for patients with complicated appendicitis, therefore allowing surgeons to better inform their patients regarding the risks and benefits of interval appendectomy. A retrospective chart review of interval appendectomies performed in all patients at our institution over a 9-year period was conducted in adults. Interval appendectomy was defined as appendectomy delayed from initial presentation with appendicitis. Complicated appendicitis was defined as appendicitis with an associated perforation, abscess, and/or phlegmon seen on CT scan. During the study period, 6,234 patients underwent appendectomy. We identified 402 patients who underwent interval appendectomy for complicated appendicitis. The average patient age was 43.5 years, and 51% of patients were male. Periappendiceal abscess was present in 44% of patients, and 34% underwent surgical or image-guided drainage for an abscess prior to appendectomy. The mean age of patients with an appendiceal neoplasm was 56.6 years. The range was 30 to 80 years. Patients with an occult appendiceal neoplasm were significantly older than patients without. Female versus male sex was not associated with a statistically significant difference in the incidence of neoplasm. Patients with an appendiceal neoplasm were more likely to present with an abscess, however, this finding was not statistically significant. The average time to interval appendectomy from initial presentation was 87 days and was not significantly different for patients with an appendiceal neoplasm versus those without a neoplasm. The overall incidence of laparoscopic converted to open appendectomy was 2.2%, and patients with an occult neoplasm were more likely to be converted to open appendectomy, 8.3% with a neoplasm versus 1.6% without a neoplasm. A total of 36 appendiceal neoplasms were discovered on final pathology for an overall incidence of 9%. Types of neoplasms found include low-grade appendiceal mucinous neoplasms, neuroendocrine tumors, adenomas, adenocarcinoma, and adenocarcinoma ex goblet cell carcinoid. Appendiceal neoplasm incidence increased with increasing age. Patients under the age of 30 had a 0% incidence of occult neoplasm, whereas patients 30 years and older had an 11% incidence. Patients 40 years and older had a 13% incidence. Patients 50 years and older had a 16% incidence, and patients 80 years and older had a 43% incidence of occult neoplasm. We report a 9% incidence of appendiceal neoplasms in 402 patients undergoing interval appendectomy for complicated appendicitis, rising to 11% in patients who are 30 years and older. Other recent studies report an even higher incidence of appendiceal neoplasm. Malinian et al. Found an appendiceal neoplasm incidence of 20%, rising to 29% in patients 40 years and older. In Wright et al.'s series of 89 patients, they found a 12% incidence of neoplasm, with a 16% incidence in patients over the age of 40. Furman et al. Found a 29.4% incidence of mucinous neoplasm in a series of 17 interval appendectomies. Two consistent points emerge. One, the pathophysiology of complicated appendicitis is distinct from uncomplicated appendicitis and carries a significantly higher neoplasm risk. And two, the risk of neoplasm increases with age. Of the neoplasms found, 17% required additional surgical treatment and/or chemotherapy. 36% underwent additional workup and/or surveillance imaging, and 47% required no additional intervention. Interval appendectomy likely spared many of these patients additional treatment that would be needed if the disease had been allowed to progress unchecked. Low-grade appendiceal mucinous neoplasm was the most common type of appendiceal neoplasm in our groups of patients. Appendectomy alone can be curative for this. However, if this neoplasm ruptures, it can progress to pseudomyxoma peritonei, which is a morbid and potentially fatal condition. None of the low-grade appendiceal mucinous neoplasms that were found in this study required additional surgical treatment other than one patient who was treated with a wedge cecectomy due to a positive margin on the appendectomy specimen. Interval appendectomy allows for earlier identification of patients with low-grade appendiceal mucinous neoplasms, which may have otherwise been missed and allowed to progress to pseudomyxoma peritonei. All 5 of the patients with adenocarcinoma of the appendix required additional surgery, and 4 out of 5 were treated with adjuvant chemotherapy. None of the well-differentiated neuroendocrine tumors or adenomas required additional surgery. Weaknesses of this study include its retrospective nature. Additionally, the outcomes of patients who presented with complicated appendicitis and never underwent interval appendectomy are unknown, as patients with complicated appendicitis who never had interval appendectomy were not identified. It has become apparent from this study and the work of others that complicated appendicitis stands apart from simple acute appendicitis and should be managed differently. It's also clear that the risk of acute occult neoplasm increases with age. In light of the 11% appendiceal neoplasm incidence in patients 30 years and older, we recommend interval appendectomy in all patients with complicated appendicitis over the age of 30. Thank you.